from KBIA and the Reynolds Journalism Institute. On air and online, this is Intersection.
Hello and welcome to Intersection, where people and ideas meet online and on KBIA. I'm Ryan Famuliner. The United States Veterans Health Administration has recently been under national scrutiny after reports that hundreds of veterans were on waiting lists at some VA hospitals for more than 30 days. In some cases, dozens of people had died while still on waiting lists to receive care. Moreover, there's been evidence of efforts at some hospitals to hide evidence of those long waiting lists. Congress is discussing the issue, and the Veterans Affairs Secretary resigned last month. In the meantime, we want to know more about the issues facing the VA system and about the impact at the VA facilities here in Missouri. In studio today to talk us through it, Stephen Gaither is the Public Affairs Officer for the Truman VA Hospital in Columbia. Stephen, thanks for being here.
Thank you, Ryan.
And Doug Meyer is the Director of the Veterans Service Program at the Missouri Veterans Commission. Doug, welcome to Intersection.
Thanks, Ryan.
And joining us by Skype from Maryland is Stuart Hickey. He's the National Executive Director of AMVETS, a volunteer-led veteran service organization. Stuart, thanks for joining us.
Thank you.
And for you and our audience, what questions do you have about the situation with the national VA system? You can ask our panel by calling 573-882-8925 or email intersection@kbia.org. You could also tweet us at IntersectKBIA. We thought just since we will go pretty deep into the issue today, we thought it might make sense from the start just to talk a little bit about the VA system and maybe some misconceptions people may have about the structure of it. And Stephen, maybe you can help us out with that a little bit. We were talking a little bit before the show about what role it plays and what this VA system doesn't do as well, I guess.
Well, there's a long history in our country of providing benefits to veterans, and since 1930, the organization responsible for that within the federal government has been the VA. From 1930 to 1989, that was the Veterans Administration. In 1989, we became the Department of Veterans Affairs, a cabinet-level department with a secretary. And the department actually has three major organizations within it: benefits, health, and cemeteries. And each of those activities are very important to the veterans of this country, but they're also very different. And so lots of times people who work within benefits don't understand the healthcare system very well, and none of us understand the cemetery system very well, but we can talk generically about it. We're the second largest department in the federal government, so there's more than 300,000 employees who are VA employees across the country. And unless people are actually involved, if they're a veteran themselves or have veterans in their families, most people really don't understand much about our organization until there's some big, bold headline about somebody doing something they shouldn't have done.
Mm-hmm. And so we mentioned too that you work with auxiliary programs like Missouri Veterans Commission and different organizations like that as well. How does that fit into the overall scope of services that are offered by the Health Administration?
Well, Doug can talk about how important that partnership is for the Missouri Veterans Commission. But with that commission, they have a homes program, they have the service program, which Doug is responsible for, and they have cemeteries. And in the homes program, VA is a financial partner in those homes programs by paying a per diem for every veteran in a bed. They're a partner with the cemeteries in that they help the states who develop state veteran cemeteries develop those cemeteries and maintain those cemeteries. Healthcare ties in with the homes. Obviously the service thing, and Doug should really talk about that, but that's working with helping veterans file claims for the benefits that they've earned by service to this country.
Yeah, Doug, maybe you can help us out with that.
The Missouri Veterans Commission has three main programs. As Stephen mentioned, the Missouri Veterans Homes, the Veterans Cemetery Program, and the program, my program is the Veterans Service Program. The 7 Veterans Home provides skilled care nursing services for our veterans. And the cemeteries and the Veterans Service Program, we have 44 veteran service officers scattered throughout the state of Missouri. Their job is to help veterans file claims with the Department of Veterans Affairs or the VA, specifically on the benefits side. We train them and provide a program where the service officers become accredited with the VA, and that way we're able to take claims, send them to the VA, and provide representation for the veterans we serve.
I see. Well, and I wonder, you mentioned, Stephen, the lack of knowledge of the organization by the general public. What are some of the misconceptions, I guess, or myths that you think may be common?
Well, people don't understand eligibility in healthcare. You have to, and it's not an easy topic to go into. I mean, you go in and talk about the different priority groups and definitions that are used. So you have to have patience to wade through that, and it helps people who have a working knowledge to do that. Now, the service officers do have that working knowledge. They can help veterans when they apply for VA healthcare benefits. The other thing Doug didn't talk about is that here in Missouri, through a grants program, the Missouri Veterans Commission also pays for the service officers from the veteran service organizations. And that's a valuable service to veterans in the state of Missouri.
Doug?
Well, we have three key messages for the Missouri Veterans Commission program for our veterans. And the three key messages are, number one, see a veteran service officer. Stephen mentioned not only the Missouri Veterans Commission, but other service organizations help veterans with their claims. For instance, the Veterans of Foreign Wars, the Disabled American Veterans, the American Legion, AMVETS, just to name a few. They're all trained in helping veterans get the information they need, what they qualify for, and put that in writing. Forms have to be filled out correctly. It's if they go in and they're not filled in correctly, then they get kicked back. So we're trained to put together complete forms with the documentation necessary. And really, our goal is to try to get these claims done as quickly as possible. Now, we worked starting in 2009 trying to expedite this process because claims are taking a long time getting through the system. And the number one complaint that I receive and still receive is the amount of time it takes for a claim to get through the benefit side of the house.
Right.
Okay. So we developed what's called the Fully Developed Claim Program. And what that means is that when a claim is submitted, it's submitted with all the information that a VA rater, and the rater is the one who decides whether or not you're service connected, whether what kind of percentage you're going to get. So if we can give that rater all the information they need to make a decision on the spot, that shortens the process, and we're promised a 90-day turnaround, which is fantastic compared to a year or more what we've been facing. So we've been able to get that processing time down by doing that now. We send in maybe, I'd say, an average of 1,400 claims a month. 40% of those claims are fully developed.
Okay. Well, and so, but what I'm hearing too is, I mean, like you said, 2009. I mean, that's what we've kind of been seeing a lot, and a lot of the reporting as this has played out is that this obviously was not something that just happened. It's something that's been going on for a while. The delays in getting put into the system, or again, actually receiving care. That's one of those misconceptions that also happens when a veteran has filed a claim with Veterans Benefits. They're waiting for that decision, and if the decision is yes, then it's going to eventually lead to an amount of money paid as compensation for their service-related injury or illness. The health care eligibility is separate, and they can be receiving health care while they're waiting for that decision. But oftentimes, because people don't understand that, it sounds as if VA is just letting that veteran out there with no kind of help or support at all. And that's rather frustrating for the situations where you've provided that care in a timely manner and provided access when you're supposed to be providing it. Another factor that happens to me a lot because I am responsible for interacting with community folks and bringing them into the facility, they walk into our building, and if they've never been there before, they go, gee, this looks like a hospital, because their concept is that it's something other than a healthcare system. And you take the opportunity to help educate them and show that we are a full-service healthcare delivery system, and using all kinds of different metrics, one of the best in the country. Stuart, I wanted to get your thoughts on some of the things we've been talking about here. Again, misconceptions and misunderstandings, and especially in the wake of the news that's been happening recently.
Yeah, well, I agree with your panelists there. There's a lot of misinformation out there. But then, as you can see, even the acting Secretary of Veterans Affairs says that we have a systemic problem within the VA. As far as some of these wait lists and problems that have been surfaced here recently, and they're not problems that we didn't know about, that we just found out. Some of them are several years old.
Right. And so, I guess I talked about it briefly in the intro, but yeah, what has been some of your reaction to some of this news? Again, we've got, in Phoenix, there was a really difficult situation there where we have this waiting list with dozens of or hundreds of people on it, and some people have been dying while they're on the waiting list. And again, some hospitals have had made efforts to actually, put people on a list that was not the official list, right? So that it wouldn't factor into the time. So I mean, all these types of things, are these types of things you're saying were not new issues?
Right. There was a memo put out in 2010 about this very thing by Bill Schoenhard, who was director of operations up at VACO at the VA central office. And it went out to the field saying, we know you guys are playing these games with the waiting list. You need to cease and desist immediately. Some people obviously took heed to that. Others, as you can see, didn't. And it's, gaming the system so that they can enhance their performance and bonus or whatever, So I think the VA secretary is looking at the metrics of why someone gets a bonus and changing those to more patient-centered outcomes instead of, X amount of days on a wait list or whatever, that type of thing, which is a good thing. And should help the veteran and hopefully make, VA employees more efficient at what they do, and they don't have to pull these shenanigans to try and, make themselves look good to the central office.
Take a moment to remind our audience this is Intersection, a program of KBIA and the Reynolds Journalism Institute. I'm Ryan Famulner, and today we're talking about the issues facing the United States Veterans Health Administration and about the impact at the VA facilities here in Missouri as well. Joining us in studio today are Stephen Gaither, the Public Affairs Officer for the Truman VA Hospital in Columbia, Doug Mayer, who's the Director of the Veterans Service Program at the Missouri Veterans Commission, and joining us by Skype from Maryland is Stuart Hickey. He's the National Executive Director of AMVETS, a volunteer-led service organization. And for you and our audience, are you a veteran? What's your experience been like trying to navigate the VA system? We'd like to hear your story. Give us a call at 573-882-8925 or email intersection@kbia.org. You could also tweet us at intersectkbia. So yeah, to your point about those bonuses, obviously that's something that's very off-putting to a lot of people with the news that has been coming out in the recent months, or recent weeks rather. But what are some of the other issues that are? I mean, it's not just bonuses probably that are causing this issue, right? I mean, waiting lists don't just appear out of nowhere. Really, what it is people that need care.
There's an issue of demand and whether you have the capacity to meet that demand, and that varies across the country. Stuart talked about the performance measures, and really VA healthcare transformed itself back in the mid-90s, and they moved away from just being a hospital system to a full-service healthcare delivery system. When they took that action, when the department took that action, then they put performance measures in place to help move that change. Mm-hmm. But unfortunately, they kept growing, and more performance measures, and so that's what has driven the organization for a long time, the number of performance measures that we're evaluated on. Yes, the evaluation does tie back into the performance of the chief executive officer at the medical center, but there are lots of different metrics that are used for that evaluation. Stuart's right about the memo in 2010 and some studies that came out in 2012, and people have been reminded about using the tools that we have to schedule properly. There are obviously some issues with that, and the acting secretary has addressed some of those. Each individual medical center, as well as our Veterans Integrated Service Networks, are also addressing that. And the important thing to remember is that our number one job is to deliver quality health care to veterans. So we can use this to do a better job. We can strive to meet that primary mission. And that's really what it's about.
Sure. Yeah.
From what I see on the benefits side of the house is, for instance, when I started with the Missouri Veterans Commission back in 2002. The state of Missouri had somewhere around over 550,000 veterans in the state. Today, we have just under 500,000. The veteran population has continued to shrink and will continue to shrink. We are in a period of war right now. We have a volunteer force. We have people coming back from multiple deployments with a high number of issues, higher than what we've seen in the past. We had a person come into one of our facilities and put in a claim for service connection, and service connection means that you had an injury or an illness on active duty that has lifelong consequences or is a continuing disability throughout one's life. Put in for service connection for 30 disabilities. Now, 10 years ago, you might have said, well, that's not going to happen. You're not going to get service connected for 30 issues. That person got service connected for 15 issues, came in and applied for 20 more new issues for service connection, and probably will no doubt get service connected for many of those issues. Now, I talked to a veteran just this morning. Service connected. How many specialists do you have to see for the number of issues that you have besides your primary care physician? He named 5 specialists. I had a phone call the other day from a person who was helping a veteran, and they were deciding what this veteran needed the most. If they needed pain management because this veteran had injuries to the legs, was a survivor of, the lone survivor of an attack, has mental health issues, and numerous other issues that it takes specialists to take care of. So the demand on the services, now you have appointments for pain management, orthopedic, mental health, you have hearing loss, and audiology, and so on.
Yeah, well, this gets to one of the questions we have in the chat room, actually, from Shirley. I mean, does the VA assign an actual caseworker type of person to help usher a client through the process? And it might maybe cut through some of the redundancy that you're talking about here. Maybe,
well, I can talk about what we do at Truman VA,
yeah,
Ryan. And with the returning combat veterans from Iraq and Afghanistan, there is a special program within the department, OIF, OEF, OND, so Operation Enduring Freedom, Operation Iraqi Freedom, Operation New Dawn. And every VA medical center has a program manager and a case manager for that population. We've obviously focused a lot of our outreach on returning combat veterans over the last decade, and we've been more effective than ever before in reaching out to those. It's about 57% of the eligible returning combat veterans have received care or will continue to get care from VA. But at Truman VA, we have a seamless transition clinic. And the first visit that those combat veterans make to our facility, they not only see the primary care provider that they're going to be assigned to, but they see mental health folks and they see rehab folks if that's going to be part of the treatment plan. And within that first visit, a treatment plan has been developed for that individual. And that's eased that transition into the VA healthcare system for those individuals. It's been very successful. It wasn't unique to Truman VA. We stole the idea from another VA medical center, and there are others across the country that do the same thing.
Yeah, and Stuart, I wonder your national perspective on that, and whether there's still may get some efficiency being lost there, possibly, and there may be more to be gained.
Well, that's some of the things that during all this VA scandal, whatever you want to call it, discussion on VA reform is efficiency and effectiveness of not only the VHA, but the VBA. And as far as the cemetery affairs go, they have the highest rating of customer satisfaction in the VA, which, sort of a joke.
Actually, Stuart, it's the highest in the country for any kind of an organization with the American Consumer Satisfaction Index.
No one ever complains. But seriously, they do an excellent job at the. I just went to their undersecretary's retirement on Friday, and he's a guy that worked his way up from working in a cemetery to being the undersecretary for cemetery affairs, and he knew every aspect. And their motto was, we only have one chance to get this right, and they do an excellent job. The VHA, a lot of veterans you talk to like the care they get at their veterans hospital, and they like their physicians. Their biggest complaint is getting in to see them. Once they can get in to see them, they like the care. It's just that they can't get in there to see them. And of course, that varies across the country, but that is one of the main concerns that we've had recently with all this news media coverage of the VHA is, of course, the waiting list and getting in, with people in Phoenix, it's where it started, dying on the list and all that kind of thing. But I don't think many people argue with the level of care that they get from the physicians and nurses. One of the recommendations that we've made, and we have them on our website at amvets.org, and we've given them to the Secretary of VA, the Undersecretary for Health, the White House. One of them is the panel of doctors or patients that doctors at VHA see. If you're a primary care physician, you might have one doctor per 12 or 1,300 patients. Whereas a primary care physician out in the normal world, I'll call it, will have a ratio of 1 to 4,200. So one of our recommendations is you only have X amount of doctors. Maybe you need to, up the panel of patients that they see, because we've had reports of, doctors that saw 3 patients a day. That's ridiculous, especially when you have a waiting list.
Yeah.
And if nothing else, doubling that panel at least would theoretically cut your wait list in half automatically.
Yeah.
It's
kind of related to one of the questions we got on Twitter just now was how do wait times in the general community get reported, and how do they compare to the VA? You're talking a little bit about some of that process, but are the access standards different, I guess, and what are,
I worked in healthcare 11 years before I came to this job, and I ran primary care groups. Our standard was same day or next day appointment. So
which is not what we're hearing with the VA.
There is not a wait list. You either get in today when you call, or you get in tomorrow. Now, some VAs and a lot of doctors' offices, they will have a hybrid scheduling system where they'll put in the schedule no appointments for a period of time and take walk-ins. And then the rest of their day may be scheduled, which is something that, the VA could look at doing.
And there are individual facilities that actually do that. So
because my theory is people are sick today. If you have to wait 2 or 3 weeks to see the doctor, you're either cured or dead. So, if you've got strep throat or something, you don't want to wait 3 weeks to go in and
there, Stuart, there are mechanisms in place for someone who's already in a primary care team with a primary care provider. They can call their team if they've got an urgent situation. The team will try to work them in that day, or they'll be referred to the emergency department. The issue that has gotten all the attention is the new patient and when that new patient appointment is made. So the standard that we were operating under was 14 days, and the acting secretary has thrown that out. But a lot of the data that reported, and I want to talk about the data that was reported, because in the last 2 issues of data released by Washington, they're releasing prospective data. They've taken numbers, they've crunched those numbers, and it's a prediction of what's going to happen over a period of time. But it was presented as if that was the reality. So these very long waiting times were reported. We wondered the first time it came out where those numbers came from, because it wasn't even close to what our own experience here in Columbia was. Now the second issue, there are 28 different columns of data that were released last week, and the last 3 are a retrospective look at actual results from the end of April. Well, we got the results from the end of May today, and they're even better than they were in April. But we were challenged because the public got this data release, and it was very large numbers and long waiting lists, and it didn't really connect with what we were doing.
Sure. But what I have heard throughout this conversation a little bit is that anecdotally, I mean, Stuart was just talking about it, that it's not really a secret that there's going to be some time before you get seen at the VA, or it's not going to be
Not
quite
necessarily.
as simple. Okay. Well,
Okay.
I guess in many places, how about that? But I guess that's a good question. Is the reporting that you've seen, obviously you have some issues with some of the numbers that have been used, but is that an accurate reflection in some ways that there is? I mean, there's still something to be dealt with. That something it's gotten to this point that there's delays in some place for some reason. And how did
There's
that?
no question that there are delays, and there are delays at any healthcare facility,
Right.
Whether it's under the federal government or in the private sector. What we do know is that there is a demand for services that varies across the country, and some facilities are challenged by that increased demand and challenged with being able to hire the providers that can provide that service. We run into some of those problems here in Missouri. We've got our medical center here in Columbia. We've got 8 community-based outpatient clinics around the state. And some of those clinics, we have difficulty in recruiting the primary care providers. And if we lose one of those providers, we have difficulty in replacing that provider because it's not necessarily a place where the provider wants to live.
Right.
Living in Columbia, Missouri, and Stuart, you don't know about Columbia, but Columbia's a pretty livable place with the University of Missouri. And in the environment that we have here, it's a little easier for us to hire physicians at the medical center. It's more challenging for the outpatient clinics. The other part is what we pay providers.
Mm-hmm.
And in the federal government, there's a restriction on what you can pay, a maximum that you can pay for providers. Some of these specialists garner a lot of money, and it's twice what VA can pay for them. And so it's not going to be an attraction for some of those medical specialists or surgical subspecialists who can get a lot more money practicing in the private sector.
And Stephen, we just have a brief minute before we get to the break here. Stuart, rather, I wanted to get your thoughts on that same kind of question, whether you think the reporting that's been done has been accurate on the whole or not, and how things got to this point.
I'd say that the reporting, I mean, they report what's out there. Of course, they're going to sensationalize, an exam. I mean, they started with Phoenix, and there were problems there. Even the President of the United States has admitted that. And that was blown, just way out of the water. And then they started looking at other places, and then I think the last count I had was like 42 across the country that had all these problems.
Mm-hmm.
And that was from the Inspector General.
Sure.
Out of 1,700 sites of care.
Sure. And unfortunately, I asked you a big question. We'll have to come right back to the answer again right after the break. Take a quick break here. This is Intersection, a product of RJI and the KBI and the Reynolds Journalism Institute. Our guests in studio today are Stephen Gaither and Doug Meyer. On Skype is Stuart Hickey. I'm Ryan Famulner. We'll be right back.